Good afternoon, distinguished ladies and gentlemen. This session is how to why is addressing heart failure important in our health system. Heart failure causes substantial economic and social burden in worldwide. There are 32 million people in Asia Pacific region suffer from heart failure. Heart failure affects not only high mortality but also high rate of admission. Today, we will discuss with 4 experts from several countries from Asia Pacific country to discuss about burden, awareness, how to diagnose, how to manage, and how to improve outcome of heart failure management in Asia Pacific region. That's my great pleasure to introduce 4 experts from several countries. The first panelist is Dr. Christine Verdicchio. He's the CEO, Chief Executive Committee Heart Support from Australia. The second panelist, Professor Hoang and Tien from Wei University of Medicine and Pharmacy in Vietnam. The third panelist is Ms. Paisante. She's lead Asia Pacific Disease Area Strategy from Roche Diagnostics Asia Pacific, Singapore. And last panelist, Dr. Aekarach Ariyachaipanich. He's heart failure specialist from Heart Failure and Transplant Cardiology, Faculty of Medicine, Chulalongkorn University, King Chulalongkorn Memorial Hospital from Thailand. Let's start with my first question about burden of heart failure. Data from Caroline Live show that patients with cardiovascular disease in Asia Pacific region was 10 years earlier than Western country. This is so important. So I will ask for Dr. Tien for what is the burden of heart failure in Vietnam, in your opinion, and how is heart failure affect to healthcare system in your country?
Hello. Yeah. So thank you very much for your question, ladies and gentlemen. Now in Vietnam, heart failures are the major burden of cardiovascular disease. You know that the prevalence is nearly 5% of the population suffer from heart failure. And in Vietnam, when the patient come to hospital, they have the severe from the last stage of heart failure, because in Vietnam, when they feel very tired or very worse, they come to hospital. They not check their health every, for example, 1 month, 3 months, 6 months, for example. So it's very the large burden for us, not only the social but also the economies. And we estimate that the price, the amount of money for one heart failure patient is nearly $5,000. As you know, Vietnam is the low to middle income economies according to the WHO, and so with the price nearly $5,000 is higher than maybe 1.5 or double times compared to the income for the patients in the Vietnamese. And you know that not only the price for the care of the heart failure patient, but also the price for the follow-up the patient, and also the families have to take care of the incapabilities of heart failures when the patient has severe conditions. until now, similar to other countries, heart failure is very is a burden and also the big problem for our healthcare system.
Thank you for your question. Dr. Tien showed that there's a big burden in Vietnam. So I will move to in Australia. Dr. Christine, how is it different from the Vietnam?
I think it's quite consistent globally, really. For Australia, heart failure accounts for about 1% of the population. Around about just over 100,000 people suffer from heart failure. And in terms of hospitalisation rates, around about 160 or 170,000 people a year are hospitalised with heart failure as a principal primary diagnosis. And so when we think of the three conditions of principal primary presentations to hospital, we have AF, heart failure, and acute coronary syndrome, so heart attacks and those type of things. It's an important condition. I guess also did my PhD in that kind of area with AF and things, and we know with AF increasing globally as well with the prevalence, many of those people actually with heart failure are undiagnosed sometimes, or have what we kind of see as a heart failure with a preserved ejection fraction as well, so sometimes can get missed with diagnosis. So it is, does place a significant burden on the healthcare system, and I guess what we typically find with heart failure patients is that they probably suffer the most, really. Medications are quite good, and you can do, cardiac rehab, and we'll get into that later, and exercise interventions and titration and those type of things. But, the heart failure patients sometimes suffer the most long term, and it does really affect their quality of life. Whereas other type of conditions, especially heart attacks and things like that, stents and bypasses are quite good actually getting them back to pretty good baseline areas. So I think it's pretty consistent when you think about various areas. For us, though, it does affect. There are differences between regional Australia and I guess Metro Australia, which I would assume is probably also comparable across Asia or the world globally, and also between we have Indigenous Australians and as well. Also, the health inequities that exist amongst that population, unfortunately.
Okay, thank you for your question. And Ms. Paisante, do you have any comment?
Actually, I want to share two countries. First is where I come from, and then where I'm living in now. Actually, being a Malaysian, I'm very saddened to know that Malaysia has one of the highest heart failure prevalence in Southeast Asia. So with I think more than 700 cases per 100,000 populations, this is a really high number, and it's growing steadily. And what is more alarming is that in 2015, a survey noted that 1 in 5 of these patients, heart failure patients, actually get readmitted 30 days post-discharge. So this is a very serious problem. And then, of course, in Singapore, where it's a high-income country, everybody would think that it is better managed. But heart failure is also very extremely prevalent in Singapore. And 5% of the population, very similar to Vietnam, also is suffering from heart failure. And what we see when we compare it against US as well as Europe, with only 1 to 2%, I think there's a huge gap that we need to address in this part of the world. Thank you.
Thank you. Dr. Aekarach, do you have the data from Thailand?
Yeah. So in Thailand, it's even worse, because we don't even know how many people have heart failure. That's how bad it is. So the burden is, I'm a heart failure cardiologist. Awareness of the syndrome itself from the public, from the patients, even the high-risk people, they don't know it, right? People know like chest pain is heart attack, facial droop is stroke. But if you tell them leg edema cannot lie flat, they say what? Cirrhosis or kidney disease. So actually in Thailand, we don't have the prevalence yet. We know the admission is around 20 per 100,000. This is from the Ministry of Health. we have to kind of congratulate ourselves a little bit that we get through the acute phase of cardiovascular disease, right? And then the population become aging. That's why the heart failure being more recognized now. The economic burden of itself is really high because of the readmission compared to other cardiac disease. This is really chronic with relapse and remission. So mortality is one thing, but the hospitalization will eat tons of the economy spending of the country. And with the simple treatment, the readmission rate, so just in case you are not in heart failure field, people with heart failure, after the best treatment and left the hospital, 1 in 4 will be readmitted again within 30 days. So what we have done a month ago, they come back in again. So that is the burden. Yes, that's about it.
Thank you. But data from literature, I think the prevalence of heart failure is about 1 to 3% in the worldwide. In Thailand, some studies show that less than 1%, but I'm not sure for this the data. And we know that nowadays, due to aging society, trend of heart failure with preserved LV ejection fraction is increased. But the heart failure with reduced ejection fraction, I think now is stable in Thailand. But in the heart failure preserved is trend to be increased. So we move to the second issue for discuss today is about the awareness that Dr. Aekarach mentioned, because awareness bring to the big burden. From Asia Pacific, APSC survey found that evidence of low awareness about awareness of heart failure. So I will ask all panelists for your opinion in your country, how aware of people and physicians for the heart failure awareness in your country. Start with Dr. Christine.
I think it's a mix. I think in general, cardiovascular disease is, people are aware of it, but they never believe it's going to be them. And so trying to get people to take up primary prevention strategies by going to their primary care physician early and to try and identify issues, or perhaps if they start to have some shortness of breath and these type of other symptoms of heart failure, whether they put it down to old age or just being unfit or these type of things. And so there are multiple awareness campaigns in Australia through a whole range of mediums. But I think even the conversation before with the prior sessions, that there's so much noise in the media. There's cancer, there's respiratory disease, there's a whole range of other things. And then you got heart disease, and then within heart disease you got AF, stroke, heart attack, cardiac arrest, heart failure. It gets lost. And so, I would always say that we can do more. In actual fact, I've always kind of been going to America for a few conferences. Some of those commercials for drug companies can be quite depressing. I think they're quite full on, and the side effects there's always one which always says death, which is quite full on, especially when you're watching TV. But there's a part of me that feels like governments should also take that up, and whether industries start to drive awareness campaigns on paid media, or governments start to raise awareness of these things. But I would still say that there's still more to do in the space.
Okay, thank you. Dr. Tien? Okay.
Yes, in Vietnam, the awareness of the heart failure is not similar to all the disease. In Vietnam, we have the Vietnam Society of Hypertension has conduct the MMM program. MMM means the measurement month is the program from the International Society of Hypertension. And with the hypertension, we raise awareness of the patient because we conduct the survey and conduct blood pressure measurement every cities in Vietnam every year in the month, and so we can calculate the blood pressure of the almost the people, so raise the awareness of the patient. But heart failure is very difficult to raise awareness in Vietnam. Even though we have the Heart Failure Society, and me as the Vice President of Vietnam Heart Failure Society, but you know that the patients only come to hospital in the end stage of heart failure. They not recognize that when the patient has suffer from, for example, hypertension, atrial fibrillation, ischemic heart disease, and some other conditions, for example, valvular heart disease, they also classified at the stage age of the heart failure. So the patient doesn't know that. They say that, no, they not suffer from heart failure, so you scare me. But you know that when the patient has to realize that when if any cardiovascular disease that they suffer, they should calculate at the heart failure at early stage. And so in Vietnam, now we follow up some big program of the European Society of Cardiology, for example, Aekarach, heart failure. And also with the American Heart Association program, for example, gone with the guidelines. So with the big program from two big society of cardiovascular in the world, and now in Vietnam, my society can record the heart failure patient, and with the patient with the health records of heart failure, we can raise awareness. But I think in the future, we need to raise awareness in the community, especially in the rural, because you know that the rural people in Vietnam is 60% of the Vietnamese people is in the rural, not in the urban. So at the rural regions, we cannot give the medical education, medical awareness to the patient. So I think we need to improve in the future. Yeah.
Thank you. Miss.
I think we need to really raise awareness of heart failure among the primary physicians, because a lot of time, I think in our regions, when people get sick, when let's say they feel breathless, they first contact will probably be the general practitioners, the GPs, where they are most accessible. But currently, I think we don't blame the primary physicians because they have so many different types of medical conditions that they have to attend to. So their awareness of heart failure may be low. So I think it will be worthwhile to raise the awareness among the primary physicians so that they can be trained to identify the symptoms, signs and symptoms of the heart failure early and be responsible enough to then refer them to cardiologists like Dr. Aekarach for them to be treated early so that they are being screened early, treated early, and then to save lives. I think that is very important. The other thing is, I think before I come to this conference, I didn't know that there is patients group in our regions because the voice is very low. We hardly even know that it exists. Until yesterday night, I know that Malaysia has a patient advocacy group, Indonesia also. So I think they need to also raise a lot of awareness among the patients. Because, for example, my late father, he did not know that he has heart failure until very late stage when he collapsed and ended up in the emergency room. When I saw his leg is swollen, he just told me, I just put on weight. This is put on weight. I'm not having serious problems, so don't ask me to go and see doctor. So I think patient groups also needs to also give a lot of awareness to the patients so that they are more aware of their signs and symptoms so that they can be treated early. Because I think heart failure is a one-way train. The end stage is heart transplant or death. So if we do not identify early and stop the progressions of the disease, we are going to spend a lot of money in the healthcare system to treat these patients. Thank you.
Thank you.
Yeah,
Dr.
totally
Aekarach.
agree. The awareness of heart failure is understandable lower than other cardiovascular disease. The treatment itself, the syndrome, is a lot later compared to like MI or stroke, right? I think the sound from the other room. This is the problem when you start talking about heart failure. Anyway, let hear some number, right? In the US, the number of people who dying from heart failure is higher than all cancer combined plus HIV, right? All the diabetic patients, they don't want to have heart attack, they don't want to have the limb cut, but they're more likely to have heart failure than other stuff. The renal disease patients, they don't want to get dialysis, but they're more likely to die from heart failure. I'm not sure why awareness is really low. Maybe the name of the syndrome itself, depends on your country. Think about the wording of the heart failure. Like in Spanish-speaking country, it's a heart insufficient. In kidney disease, they would call it chronic kidney disease. If we call it like chronic heart disease, heart failure is actually end-stage heart disease, basically, right? The pump is failing. And with the knowledge of this syndrome coming to this region later than Western country, I think a lot of focus has been putting on heart transplant, LVAD, advanced care, which is kind of toward the end of the syndrome. And that is unfortunate, yeah.
Thank you, all panelists. I think raising awareness is very, very important in patient and physician awareness, and especially when the primary healthcare physician. Today, in this conference, we have a patient organization to join with the conference, so it's a good opportunity for the raise awareness to the public in the patient awareness. But I think just only patient or physician awareness is not enough. The stakeholder is important, so we have to raise the awareness of the policymaker on need to prioritize as national policy to the cardiovascular disease prevention. With this conference, we have stakeholder for this conference also, so it's good opportunity to do this. So we move to the next issue. The next issue is how to diagnose the heart failure. If we know for awareness of the symptom, but due to non-specific symptom of heart failure, use of cardiac biomarker may be useful in primary setting nowadays from the expert recommendation. So in your country, in Vietnam, do you consider the use of cardiac biomarker to help for diagnosis?
Yes, thank you very much. I think the diagnosis of the heart failure is a very important process to manage heart failure. You know that very early for diagnose the heart failure, we can use not only the marker, but also we can use, for example, some genetics. Genetic, and also is the choice for we very early stage diagnose heart failure. And even now we have some pilot study to use generic genetics to find out what the gene is will make the heart failure in the future. But I think the most accurate procedure to diagnose the heart failure is we use the biomarker, especially we use the anti-proBNP and BNP. In Vietnam, we get it in the guidelines, national guidelines, to use when we evaluate the heart failure patient. We should use the biomarker, for example, anti-proBNP and BNP for the patient with acute heart failure and for the patient with chronic heart failure. And when we check about the exactly accuracies of the biomarker, we see that it's very reliable marker for diagnose the heart failure. Not only the reduced heart failure. It means the ejectional fraction is below 40, but in the patient with the mild reduced heart failure, is the EF, it means ejectional fraction, ejections, yes, between from the 40 and 80, and especially in the patient with preserved EF, we can also use the biomarker to evaluate the heart failure. And we combine with the echography. Yeah, we calculate, for example, the left atrial enlargement with the fractional shortening reduced, and we can apply very successful in the diagnosis when the patient is in hospital. And in the outside hospital or in the community, we difficult to use it means the highest accurate of the BNP and proBNP. So we can only use the point of care testing. It means it's the very small machines, and we take the blood sample and then we calculate. But in the community, it's the appropriate solution for diagnose heart failure. So I suggest that we should continue and keep using the biomarker, especially in the NT-proBNP. NT-proBNP is more exactly compared to BNP for diagnose heart failure, and also not for diagnose, but we can follow up the response to the heart failure treatment, and it's very important for diagnose, follow up of the treatment of heart failure patient. Yeah.
Do you have a problem for the accessibility to the test, especially in the rural area?
Yes. In Vietnam, because the price of the test is also high. One test is about $20 US. So when we do a lot, maybe it can test a lot of results. Yeah.
So the next question I will ask for the Ms. Paisante. From industrial perspective, what action do countries need to do to improve heart failure diagnosis with novel cardiac biomarker, and how can private sector help for this problem?
Thank you for this question. Actually, I must say that although proBNP has been launched more than 20 years ago, but in a lot of the countries in Asia Pacific, the test is not very well adopted. Of course, Vietnam is a very good examples of a well-adopted market, but in many of the countries, this test is not really well in use, although it has been strongly recommended by international guidelines as diagnostic marker for heart failure. So I think a lot of work needs to be done, and also in the recent publications 2 years ago, Prof. Mebaza has actually published a new protocol for treating acute heart failure, which is strong HF. And this particular protocol has actually revolutionized the whole entire treatments and management of heart failure, whereby last 2 weeks, and I'm in Japan, I actually saw some preliminary data of the use of this protocol, and we can actually see that the ejection fractions of the patients actually improve within 3 weeks. So this has actually shown very good protocols to be used, but a lot of the clinicians are worried about safety. So what is there one thing that we can use to actually ensure safety? Pro-BNP is the driver for safety. It's act like a safety belt when you want to drive fast, because in strong HF, they recommended a rapid up titrations of the drugs to up to 100%. Only 1% of everybody in this world is only using GTMT at full dose. So if everybody can use this to a full dose using anti-pro-BNP as a safety marker, I think we can change how heart failure can progress, because in this study we can actually see that the results of the endpoint is 34% reductions in mortality as well as readmissions rate. This morning, Dr. Reddy was saying the CVD Alliance vision is to reduce 1/3. I think if everybody can implement strong HF, we are there already. So I think this is something that we need to really do for heart failure. How can industry help? So a lot of people said, oh, the strong HF does not have Asian data. What we did was we brought in Prof. Mebaza to a lot of the markets in Asia to actually share with them the experience. So we are bringing experts from overseas to bridge this knowledge gap, as well as also help the experts here to generate local data so that they are more comfortable with what they are doing. Of course, lastly, we are also part of the sponsors for this kind of programs, whereby we are also bringing in patients group as well as policymakers to actually discuss and also highlight the urgency of paying attention to heart failure. Thank you.
Thank you for your answer. So you may make for some project to help for the heart failure diagnosis in this region. Because the time is running out, so I will move to the next question about the long-term care. Because heart failure is a chronic condition that need for the follow-up, or the medical adherence, or they get the optimal medical treatment, and also cardiac rehabilitation, and heart failure clinic that we will discuss later. So my question is about the cardiac rehabilitation program for the heart failure patient. In Vietnam, the cardiac rehabilitation program is still low from available data. So do you think so? And what is the contribute factor for this problem?
Yes. In the previous times, in the beginning of the conference, I see that we summarized the index for the system ready for the cares of the medicine care. The Vietnam is still very, not in the high position, it's in the base. And overall, the Vietnam still to improve a lot of about the policies, about the insurance, about the overall index for the medicine, especially in the rehabilitation. In Vietnam, actually, we still lack the doctor or the physician who work in rehabilitation. In Vietnam, we estimate education that after the one doctor finish the regular doctor, and they will to study more about the cardiac rehabilitation. Then they can do the heart rehabilitation work. It takes a long time, and actually we still lack of the doctor, because not a lot of doctor want to become the rehabilitation doctor, and so it's the first problem. The second is the insurance not cover. It's only a part of the cardiac rehabilitation. So when the patient, that because the heart failure patient has to administration is very repeatedly and a lot of the time after the patient has discharged from hospital. So they need the long time very harsh intensity of cardiac rehabilitation. So in Vietnam, the number of the patients receive the fully cardiac rehabilitation is still very low, and because I already said some reason, and I think we should concentrate in the cardiac rehabilitation. We only have it means we are concerned about the patient after cardiac surgery. We have the cardiac rehabilitation. We're very successful in the take care of the patient after the cardiac surgery. But the heart failure is very the big part of the patient, and so a lot of the patient not receive the enough cardiac rehabilitation to improve their quality of life. And yes, it's also the big problem. I think that we need more cooperation about international cooperation, more funding, more policy to concentrate in the cardiac rehabilitation. Yeah.
Thank you. Dr. Christine, Australia is the only country in this region which had excellent coverage of cardiac rehabilitation program, over 150 program, compared with 0 to 30 program in Southeast Asian country. How do you do different? And do you suggest, or how may some of this can be applied to other countries in this region?
Having recently wrote the Australian guidelines for cardiac rehabilitation, I can assure you that out of the 150 locations, they're not doing it well. And the reason why we wrote the guidelines was because Australian cardiac rehabilitation compared to Europe and America were quite conservative. Our guidelines, were very conservative, that we would push patients to low to moderate, whereas recent guidelines from ESC, AHA showed that moderate to high levels of intensity of exercise, dietitian, psychology, the kind of full multidisciplinary approach is what's needed. We do have generally good coverage. There are the limitations is that patients that present to hospital, only about 30% of them are offered cardiac rehabilitation. Only 30% of them take it up. So in actual fact, only 9% of patients actually present to cardiac rehabilitation. It varies, even within the same area, hospital network. You can have one that may be 4 weeks in duration, one can be 6 weeks in duration. So there's a lot of differences between them. But the principles are there. The heart failure is also a condition that typically kind of gets missed a lot because people are quite conservative with heart failure patients. I was quite an aggressive type of, my background was in heart failure and AF and arrhythmias and exercise, so you can actually be quite aggressive with heart failure patients. There's nothing stopping them really. And so what we find is that you get a lot of nurses who lead the programs, which is fine, but they're not trained in exercise interventions, which we know is really important for heart failure patients. But for heart failure patients, titration is important too. So that's why kind of heart failure patients are in this unique pathway sometimes, and so that's very important. But it's really about, I would always promote secondary prevention programs, whether that's cardiac rehabilitation, because it makes patients become more comfortable with their condition, that they can do, activities of daily living, they can exercise again, they can go back to work, they can go fishing, they can do whatever. And in addition to that, look, we're a peer support group. There's Tanya as well here in the room and other patient organisations. Peer support is also a really good, I would say, cost-effective way, really, because you're getting consumers who, our groups of volunteers, providing support to people who are going through that and trying to make them feel comfortable. And I kind of use the mothers group example. And if there's women here and they've had babies and they join mothers groups sometimes to kind of talk to others who are going through the same process at the same, it makes a world of difference. And so I do think that whilst cardiac rehabilitation is important, the uptake is actually an issue. And I actually think cardiologists do that poorly. Sorry, Krishna. And then, it's also a longer term thing because cardiac rehab is quite short. 4 weeks. What are you going to achieve in 4 weeks, 6 weeks? And so obviously we need to start bridging that gap to what's actually a longer term type of secondary prevention program to actually, like you said, to minimise those, 30-day readmissions and how many of them are, can actually be minimised. They actually don't even have to take place if they were probably taking their meds properly or doing the right thing. So, yeah.
Okay, thank for your information. That may be helpful for other country. Maybe join the project with your country.
Another project, wow.
So the next question is about the heart failure clinic. Because in Thailand, we have specialized heart failure clinic to improve quality of care and outcome in heart failure patient. Some hospital join with the American Heart Association, get with the guideline for the heart failure, the heart failure. So to compare and benchmark with the quality of care of heart failure to the international standard, which Chulalongkorn Hospital is one of the hospitals which join with the American Heart Association, the guideline. So could Dr. Aekarach tell us a bit for experience of the heart failure clinic and gap or area of improvement to deliver such clinic to reduce heart failure hospitalization or outcome?
Sure. As we transfer from the cardiac rehab issue, the heart failure syndrome need a lot of specialists, and not only MD specialists. It could be the nurse specialist, the dietitian, the rehab people, even outside internal medicine like palliative care, psychiatry, and actually the main member of the team is the patient and the caregiver, him or herself. The heart failure clinic is a heart failure program. Currently, most hospitals would call it a clinic, but eventually it should be the overall care that bridge the gap between home and the hospital. And hopefully it will be home more than the hospital. Like other chronic disease, it will get a lot of benefit from this new technology, big data, wearable things. We know by the data from Western countries what can we do to improve the care of the patients after they discharge home, so that when each society publish the quality improvement project, as Dr. Kasem mentioned, the American Heart Association have this thing called Get With The Guideline, and with cooperation between Ministry of Health, pharmaceutical company, AJ, we able to get funding and participate in the project. And at our hospital, we get the award of reaching the certain point. This is something that any hospital, any country can have this kind of registry or quality improvement project. I think it is a new concept in cardiology because we used to acute care more than chronic care, but any chronic care need multidisciplinary team for the disease management program.
Okay. Thank you. Because
I'm sorry. One thing that I find a lot different in this region compared to Western country that I got trained, people here tend to be really eager to join the program. They want to learn more what they can do to get better rather than just taking medications. So they would ask like what diet they should do, what exercise they should do, what else they can do. But they lack of information to find. So this kind of program help a lot.
Thank you, because the time is running out. So my last issue, the problem we will discuss today is about the health policy and patient organization. Because the gap of treatment and unmet need, I think, come from the financial coverage and capacity workforce. How our panelists you see for the more distribution of the resource, and you see the affordability being to be improved after national policy change.
So in literature, they would say eradicate rheumatic heart disease is the low-hanging fruit for the heart failure prevention in this region. I doubt that. The second and third contributing risk for heart failure is hypertension and now obesity. So how can we make people worried about their blood pressure number and BMI or waist circumference the same way that we do with smoking 50 years ago? And if we do all of that, the heart failure will be less eventually. I still think a lot about salt tax. I'm not sure we have a good data showing that the country that start using this policy can improve cardiovascular outcome. But many countries has a campaign to like salt day, salt decreasing day. That may help.
Any comment from the panelists?
Yes. For me, about heart failure, I can summarize as for the better treatment of heart failure, the first thing we have to is been very diagnosed in very early stage. We can have to identify the risk factor for heart failure. It's been prevents the risk factor, and for the doctor, we have to raise the abilities, capabilities of diagnose and treatment according to the guidelines for the patient. And for the patient has to raise awareness about heart failure. And for the policy maker, they should realize that when we treat the patient and we prevent the heart failure in the future, the government can get the various, not the result, it means to eliminate the result to save the money. So they have the policy to take care, coverage of insurance, and they can want to make the collaboration, international collaboration, to get the money to do the plan or program of controlling the heart failure. So I think the financial support and policy support is two main important supporting for treating the heart failure. And so the financial and policy is also the key, important key. Yes.
Thank you. Dr. Kristen?
I'll just say, I think that, you are right, because as part of me, I know this is a heart failure session, but in theory, heart failure to AF to acute coronary syndrome, there are many, lifestyle-based risk factors are key. And so I almost feel like if you start targeting sub-conditions under cardiovascular disease, you start locking yourself in, because then consumers might think, oh, I don't have heart failure, I'm okay, but they might have something else and vice versa. And so I do think raising awareness of these lifestyle-based risk factors are important, but as we know in the small percentage, it's not always the case. I do think to improve outcomes generally, all sectors should be engaged. Patient organisations, I think, play a really important role. I mean, if you ask me, maybe 2 years ago, I would have said, oh yeah, patient organisations, They're not interviewed for the job, so patient organisations are the best. But, actually I've seen a different side. They actually play a really important role. And then there's industry, and then there's the cardiac societies or the College of Physicians or cardiologists. I think if you engage all those key stakeholders together, even if government aren't open to perhaps policy change, and I've seen this in Australia where industry are actually leading projects now, and they're funding awareness campaigns and I think that's probably actually a really cool thing, because if the government's, saying we've got no money or we can't pay for it, I mean, industry is making heaps of profits. Saw your Ferrari outside, but joking. I think that's a great way to raise the awareness, to say, hey, look what we've done already. This is the data that we got from it. Maybe you should jump on this from a government perspective and actually continue on with this work. So I do think that, patient organisations in conjunction with key stakeholders can really play a difference in raising awareness. But I don't think we should just focus on one disease area. I think that, we have to be smart from a cardiovascular disease perspective to really get it out there about heart disease in general.
Thank you. For the all comprehensive discussion today, I think today we learned a lot for how to improve the heart failure management and heart failure outcome. So in the last of the session, do you have any comment or question from the floor?
Thank you very much. I have a question actually, which is very interesting, personal topic to me. My name is Aiste. I am leading a heart failure organization in Lithuania, a small country in Europe. I as well work with Global Heart Hub, which is an alliance for patient organizations. But I would like to ask a question which was touched on a little bit. So I'm a survivor of heart failure. I lived with left ventricle assistant device over 3 years, and now over 3 years I'm living with a heart transplant. My question to the patient organizations and the clinical specialists would be, what support do those specific patient groups receive in your countries, and what could be potentially improved? And on the same time, I would like to ask industry perspective, what are prospects of improving the medication, the treatments for the heart transplant patients? Because we know the current medications, they are working well. They're amazing, they're doing their job, but they have quite a bit negative impact on the bodies. Thank you very much.
Dr. Aekarach, for the
Yes,
answer.
When you say that you live on the LVAD and being on the heart transplant list, that means a lot. I think most of the talk has been dedicated to early diagnosis of heart failure, and in your situation is more toward advanced heart failure or end-stage heart failure. In our country, the patient usually get information from the heart transplant center, what treatment they should undergo or should consider. I think currently in this field of advanced heart failure, there has been talking a lot about shared decision making because it's so complex. Not only heart failure, like severe aortic stenosis. Should the patient go to procedure A or procedure B, the risk and the benefit, and also the coverage in terms of the payment. In Thailand, we still use some of those tools that we translate by ourselves. We don't have the patient advocate group in Thailand yet, but we hope we will have one day. One thing that has been I question myself is how the group, I heard from the patient with the kidney transplant waiting list. I heard that sometimes they get the wrong information from within the group. So any patient group in our region maybe should be co-organized with medical society or the government of some sort. Yeah.
Yeah,
Okay.
I would like to answer more. That's the in Vietnam, we has a lot of the patient of the heart transplantation is the end stage of heart failure, and we give the heart transplantation. And after that patient, you know that we have to use a lot of the medicine. It's almost 4 main types of the heart failure medicine, and also the medicine for immunosuppression. And so it's a very large amount of the money for the patient. And that patient, our government will give the insurance for the patient, because with the insurance, the patient will suffer from, will give the medicine, suitable medicine, optimal medicine for long lasting after heart transplantation. And also with the patient with left ventricular assistance device. I think that we should tailor the guideline, tailor the recommendation for a very specific patient. It's also a very good way to take care of a very specific and very it's very severe patient to get more better treatment. Yeah.
I'll answer that from a patient organisation to your question, Aster, which I totally get it. For us, our peer support programs in hospital are general. So we're open to all cardiovascular disease. We don't specialise in any areas. If we do get a patient that's heart failure, LVAD, heart transplant, which I've got a couple in our network, and they're fantastic people, and they become quite passionate that they want to give back, especially when they've gone through that process. If we have a patient that goes through that and they may not be available for one of our face-to-face locations, and we may instigate an off-the-record phone discussion over, between, hook those two people up so they can have a chat. If that's not possible, there's a person that's sitting next to you, which I would generally refer to, because they do specialise in that heart failure type of stuff and have resources as well available for that. I think I just actually referred one a few hours ago, because there's no need to reinvent the wheel. The last thing you want for a consumer is to put another resource online or something to confuse them even more. And so we just try and be practical and try and create a safe place from a face-to-face perspective where people can actually get together and talk. If there's that unofficial kind of discussion on the phone that can happen, we don't promote that. It's not something that we actively do, but sometimes with the heart failure transplant patients, they're quite special, and so you want to offer that because but we try within our best ways to kind of provide that peer support in addition to, I guess, what the medical support that they're receiving in addition to their treatment program. So, and I typically find that they appreciate speaking to somebody else who's been there, done that. It just is a different, I can't do that. It's not me. So the fact that they can speak to somebody who's been through that, experience, that living life or traveling the world or doing something, it gives them that white light. And for me, I'm lucky I got a couple of them that are available that can offer that.
Okay. Thanks for panelists. Now it's time to close this session. If you have any...
I think she also wanted the industry perspective. I'm not able to answer on drugs because I'm coming from diagnostics. But what we can do from the diagnostics perspective is like what we have mentioned just now, how STRONG-HF has revolutionized the treatment protocol for acute heart failure patients. So with that, we hope that with us helping to drive more implementations of STRONG-HF in this region, we hope that we see less of a patients that requires to go into the end stage of requiring a heart transplant. Hope that helps. Thank you.
Okay, thank you. We can discuss in the during break period. Okay, thank you.
Thank you, Dr. Kasem, and to all the panelists. That was a great session. Thank you very much.